Okay, good evening. Today we'll talk about the mechanism of labor. First thing you have to read reason for law of occipito, left occipito anterior positions. Okay. First is longitudinal lie. In longitudinal lie, because uterus is ovoid longitudinal, so longitudinal lie is occur. Cephalic present. Why cephalic presentations? Because of the bulky breech occupy broad upper pole of the uterus. What is why vertex presentation? Because attitude of universal flexions. Occiput anterior position because maternal abdominal wall accommodates fetal vertebral column. Why left occiput anterior position is more common? Because left oblique diameter of the pelvis is occupied by the sigmoid column. So the right oblique diameter is free. So baby is in left occiput anterior position. The right oblique diameter is occupied. Okay. What is mechanism of labor? Mechanism of labor. The definitions. The definition is series of movements that occur on the head. Okay, these are the series of movement that occur in the head in the process of adaptations during its journey through the pelvis, so that the smallest diameter of the fetal head passes through the largest diameter of the pelvis. Remember, very important, the series of movement that occur on the fetal head in the process of adaptation during its journey through the pelvis, so that the smallest diameter of the fetal head, that through passes through the largest diameter of the paternal pelvis at which it lies. It is first described by William Smailey. What are the cardinal movement in the fetal heads? First is engagement, then descent will happen, then flexion happen, then lateral rotation, then extension, restitutions, external rotations, and then expulsion of the trunk by lateral flexions. Okay, then what is engagement? When the greatest horizontal diameter of the fetal head, okay, or largest transverse diameter of the fetal skull, that is biparietal diameter, crosses the plane of pelvic brim. Okay, when you will call as engagement, when the greatest horizontal plane of the fetal head or the largest transverse diameter of the fetal skull, that is biparietal diameter. When this biparietal diameter or largest horizontal plane is crosses the pelvic brim, it is called as engagement. Okay, so the head at zero station is called as engaged head. No pole of fetal head is palpable for abdominal examinations. Very important. When you call as this is -5 is called as floating head. Every 5/5 engaged is called no palpable on per abdomen. +5 is crowning. Okay. In primi, the engagement occur at term, that is before the onset of labor. The engagement is happen in primi. Okay, but in multigravida, it is occur in the late fast stage of labor with rupture of membrane. Very important. In primi, it occur at the term. In those patients before onset of labor, if they are primigravida, then they have a engagement occur at term or before, that is before onset of labor. In multigravida, it is occur the late fast stage of labor with rupture of membrane. What is engaging diameter and what is diameter of engagement? Engaging diameter is the fetal head. Engaging, the fetal head is going to engage, so it is called engaging. So fetal head ka diameter suboccipitobregmatic, that is anterior posterior diameter. In transverse diameter, that is biparietal diameter, that is transverse diameter, that is called as engaging diameter of the fetal head and diameter of engagement of maternal pelvis. Here the diameter of engagement in left occipito anterior position is the right occipito, right oblique diameter of the maternal pelvis. Okay. The causes, what are the causes of non-engaged head? Why it is not engaged? What are the causes? First is if it is a deflexed head. Okay, it is a proper flexion nahi hai. In that case, it will not engage properly. Then in occipito posterior positions, if big baby is there, if a placenta previa is difficult to engage, if there is cephalopelvic disproportion, polyhydramnios, hydrocephalus, pelvic tumors, high pelvic inclinations, and functional causes of non-engaged head. One is deflexed head, an Occipito posterior position, big baby, placenta previa, cephalopelvic disproportion, polyhydramnios, hydrocephalus, pelvic tumors, high pelvic inclinations, functional. On engaged head at term in primi. Okay, you remember in primi at term or before onset of labor, head is engaged. So if it is on engaged at term in primi or in advanced labor in primi, then it is called as red flag sign. So you have to more cautious. What is syncretism? Normally, in cephalic presentation, the fetal head engages with its sagittal suture in transverse diameter of the pelvic inlet midway between the pubic symphysis and the sacral promontory, so that BPD is parallel to the pelvic inlet. Okay. In asynclitic, the lateral tilting of the head in transverse position causing deflection of the sagittal suture with respect to the available transverse diameter of the inlet. In posterior asynclitism or posterior parietal presentation, that is Leachman obliquity, is common in primigravida. Anterior asynclitism is the anterior parietal presentation, that is Neglis obliquity, the common in multigravida. Okay, ANM, you can remember by ANM. AAM, anterior obliquity, anterior parietal presentation, anterior syncretism, Neglis obliquity, and multigravida. Okay. Here you can see the anterior parietal bone is exposed. So the sagittal suture is more toward the sacral promontory. Anterior parietal bone is exposed. So anterior parietal presentation, anterior syncretism. Here the sagittal suture in the midline, pelvic inlet plane, occipitofrontal plane. So it is normal, no syncretism. Here the posterior parietal bone is exposed. This posterior syncretism or posterior parietal presentation, it also called as a Leachman obliquity. It is common in primigravida. This is anterior parietal bony presentation. This is posterior parietal bony presentation. Okay, allows engagement in flat pelvis, contracted pelvis, or large head as smaller sub superior parietal diameter, that is 8.7 cm present at pelvic inlet instead of BPD. If it is a flat pelvis or contracted pelvis or large head, in that case the smaller sub superior parietal diameter, that is 8.75 cm, is present at the pelvic inlet instead of BPD. It is 9.5 cm. Marked and persistent asynclitism indicates CPD. If there is marked asynclitism, then it is called as CPD. Correction must be before traction or rotation of the forceps delivery. Correct. Then descent. First is engagement, then descent. Descent is a continuous process. It is a continuous process if there is no undue bony or soft tissue obstruction. If there is no bony obstruction or any soft tissue obstruction, then descent is a continuous process. Head is expected to reach the pelvic floor at full dilatation. Head is expected to be reached the pelvic floor at full dilatation. This is assessment by poor abdomen and PB exam, the descent of the head. By Crichton methods, the pelvic brim, this is pelvic cavity. If is palpable poor abdomen 5 by 5, this is called floating above the pelvic brim. If it is 4 by 5, it is called on the brim. It is 3 by 5, it is not engaged. If 2 by 5, it is just engaged. 1 by 5 is engaged. 0 by 5 is deeply engaged. Okay, just engaged is 2 by 5, 1 by 5 is engaged. First is 5 by 5 is floating head. 4 by 5 is on the pelvic brim just entering. 3 by 5 not engaged. 2 by 5 just engaged, and 1 by 5 is engaged. 0 by 5 is deeply engaged. Okay, these are the 5, 2 by 5, 5, 4, 3 minus 5 minus 4 minus 3 minus 2, 1 plus 1 plus 2 plus 3 plus 4 plus 5. Okay, then descent is a continuous process if there is undue bony soft tissue obstruction. If there is no obstruction, head is expected to reach pelvic floor for full dilation. This assessment already told for abdomen PB exam. In the first stage, it is slow descent or insignificant descent. In the second test, pronounced descents. You can see here in the first test, fetal descent is almost very slow. Cervical dilatation is progressing. Acceleration phase, the active phase. It is deceleration phase of maximum slope. Second stage, the descent will increase. Descent already told. In primigravida, there is no descent in the first stage. So in primigravida, engagement is occur early, but descent is not occurring in the first stage. In multigravida, the descent start with engagement. In multigravida, the engagement is start once he goes into labor. that is with the rupture of membrane or in labor. So in descent also start with engagement. The factor, what are the factors that facilitating the descent? First one is the uterine contraction and retraction. Second is direct pressure of the fundus and breech during contraction. So one is uterine contraction. The second is the pressure of the fundus and breech during contraction. Third one is the hydrostatic pressure of amniotic fluid. Fourth one is straightening of the fetal ovaries, especially after rupture of membrane. Once the fetus, the rupture of membrane happens, the straightening of the fetal ovary especially causes descent of the fetal. Bearing down effect also causes the descent of the fetal head. Then engagement, descent, then flexion. The full flexion achieved either due to resistance offered by unfolding cervix, pelvic wall, pelvic floor. The full flexion such either due to resistance offered by unfolding cervix, pelvic wall, or by pelvic floor. The flexion is precedes internal rotation, at least coincide with it. Essential for descent since it reduces shape, size of plane of advancing diameter of the field. Force the contraction from above, resistance pelvic floor from below. The dominance of flexor muscle, two-armed lever theory is cause flexions. Flexion cause of deflection is uterine inertia, epidural block, and grand multipara. What is the two-arm lever theory? The fulcrum is the atlanto-occiput joint of the head, and the short arm from condyles to condyle to the occipital protuberance, and the long arm is from condyle to the chin. When resistance is encountered, the short arm descends first and long arm ascends, resulting in flexions. This is the lever action producing flexion of the head, reducing the engaging diameter of the fetal head from occipitofrontal to the suboccipitobregmatic diameter. Okay. This is the internal rotations. The rotation of the fetal head is occurring. Pelvic floor slope heart rules. Original hydrosis anti-respect. The pelvic internal rotation, law of unequal flexibility, slim and moire. Prerequisite for anterior internal rotation: well flexed head, efficient uterine contraction, favorable shape of mid pelvic plane, tone of levator and muscles occur at pelvic. The internal rotation occur at the pelvic floor at the level of ischial spine. The neck. So here remember the neck can withstand a torsion of rotation of maximum 45 degree, that is 1/8 of circle. So shoulder have to rotate by same degree to oblique diameter in occipitolateral positions. Okay. Crowning, when maximum diameter of fetal head, that is biparietal diameter, stretches the vulval outlet without any resection of the head even after contraction is over. Very important. What is crowning? The maximum diameter of the fetal head, that is biparietal diameter, it stretches the vulval outlet without any resection of the fetal head even after contraction is over. Extension, the successive part of the fetal, then extension is successive part of the fetal head to be born through the stretched vulval outlet by vertex, brow, face. First vertex deliver, then brow, then face. This first is vertex, then brow, then face. Okay, remember. Couple of force theory. Restitution, this is the visible passive movement of the head due to on twisting of neck. Here what happened, though, what are the rotation happen, internal rotation happen inside pelvic cavity, that is visible passive movement of that on twisting, because neck will torsion maximum 45 degree. So in restitution there is a external rotation, visible passive movement of head is occur due to it cause on twisting of the neck sustained during the internal rotation. Head rotate 1/8 of circle in the direct opposite to the internal rotation. The occiput points to metal thigh and corresponding side which it original lay. Okay. Then external rotation, movement of rotation of the head by 1/8 of circle in same direction as restitution. The external rotation is same as opposite to the internal rotation, visible externally due to internal rotation of the shoulder. The shoulder now lie in the anterior posterior diameter. Occiput points directly toward the metal thigh, correspond to side to which it originally directed at the time of engagement. So what happened? Internal rotation during when head is rotate 1/8 of circle, the shoulder also rotate 1/8 of circle. So first in restitution head is untwisting 1/8 of circle, but in external rotation the shoulder is rotated internally, that is manifest externally as external rotation 1/8 of circle opposite to the direction of the internal rotation. So this is called as external rotation. So now shoulder line in anterior posterior diameter and the occiput direct towards the metal thigh, corresponding to size which already originally directed at the time of engagement. Then birth of shoulder and trunk. After shoulder are positioned in AP diameter of the outlet, further descent takes place until the anterior shoulder escape below the symphysis pubis fast. So remember, anterior deliver fast followed by posterior. So after shoulder are positioned in AP diameter of outlet, further descent takes place until the anterior shoulder escape below symphysis pubis pass. By a movement of lateral flexions of the spine, posterior shoulder sweeps over the perineum. The rest of the trunk then expelled by lateral flexion. The position of suture, already this is onset of labor, LOT position, descent of flexions. and the internal rotation LOT to LOA to accept and direct antependicular extension beginning, extension complete, then restitution happen, LOA positions, then LOT. Okay. The summary of the mechanism of labor in Occipito transverse position, diameter of engagement is available, transverse diameter of the pelvic inlet, engaging diameter of the fetal head is subaxial pragmatic, that is 9.5 centimeter, or subaxial frontal is 10 centimeter. First engagement happen, increasing flexion happen, interrotation of the occiput anteriorly to 1/8 of circle, simultaneously rotation of the shoulder to 1/8 of circle. The crowning happen, then deliver the fetal head by extension, restitutions, and external rotation, deliver the shoulder term by lateral flexions. Head floating before engagement, then engagement, descent, and flexion happen. For the descent and interrotation, complete rotation, beginning of extension. What are the factors responsible for each cardinal movement and its significance? Engagement, where it's achieved, what is achieved, engaging diameter of the entry into pelvic inlet because of uterine contraction. Descent happen, downward movement of fetus, uterine contraction. Flexion, due to flexion causes achieve subaxial pragmatic diameter presence, uterine contraction because of uterine contraction. Resistance by cervix, pelvic wall, pelvic floor. Internal rotation, subaxial pragmatic diameter comes to lie in the epidiameter of the pelvis, uterine because of uterine contraction. Shape of the pelvis, shape of lateral muscle, elasterical. Extension, delivery of the fetal head, shape of the birth canal, uterine contraction, force of lateral muscle, maternal expulsive effort. Restitution is on twisting of the fetal neck, that is spontaneous restitution. External rotation, bring the shoulder in epidiameter, uterine contraction, shape of pelvis, shape of lateral muscle. Expulsion, delivery shoulder at whole fetus, uterine contraction, maternal expulsive effort. In summary, commonest fetal-pelvic relation, longitudinal sepal presentation, vortex, universal flexion, occipital anterior position, engagement, the cardinal steps. Engagement, descent, flexions, internal rotation, extension, then restitution happen, then external rotation happen. Common questions, already I told, these are the common mistake you have to read. You have to be careful during this viva. Improper holding of the fetus pelvis, inappropriate hand-mouth coordination, not mentioning fetus in utero, wrong chronology or cardinal movement, confusing diameter of engagement and engaging diameter of the fetal head, on the wrong direction of the internal rotation, restitution, external rotation, unnecessary explanation of the each cardinal movement, including crowning as cardinal movement. Okay.